Start of it.
Very good morning. At the outset, I'd like to thank the organizing committee for giving me this opportunity. I'm going to talk on the intraocular lens approaches for presbyopia management. So I have nil financial disclosures or proprietary interests with regard to talk. There are myriad of presbyopia solutions, and I'm going to predominantly highlight today on the intraocular lens options for treating presbyopia, which includes the trifocal, the extended depth of focus lens or the ERV lens, and the multifocal lenses. So we have a changing profile of the patients opting for cataract surgery. We earlier had the patients who were waiting for the visions to drop below 660, came with dense brown cataracts. And now we have a patient who's got an active lifestyle, who's in 60s, who drives and who plays a sport and who desires spectacle independence. So cataract surgery is no longer vision restoring, is more of a refractive surgery where we have to make them free from spectacles. Always the holy grail in ophthalmology forever, I feel, has been the presbyopia correcting intraocular lens. So we have different types here, but there's no perfect lens which would suit all. I would always request my colleagues, or even I counsel my patients and see their life style or their life profile and try to offer the best solution for them based on their day-to-day activities or their lifestyle. So we have the trifocals, the continuous range of vision, the EDOF lenses, and the fusion IOL. I'll be just talking about these lenses. Before I kickstart my talk, I'll just like to share a few case studies, three cases which I like to share here. Initially, there was this 58-year-old homemaker who had come to me who had a best corrected visual acuity of 6/9. She had incipient cataract. This was a refraction. She was in hyperope and astigmatism in other eye. She wants freedom from spectacles. The lens is almost clear, but she desires freedom from spectacles. And that's when we went ahead and did the toric trifocal implant in one eye and the trifocal implant in the other eye. These patients should be adequately counseled prior to the surgery about nighttime driving and night visual glass and halos. I'll just move the video slightly faster because want of time. It's important for you to get a central circular axis. And I do this soft cataracts once I do the hydrodissection or hydrodelination. I go for the nuclear flip or the nucleus salute technique where one pole of the nucleus lifts up. These cataracts are very soft and they cheese wire when you try to attempt to crack. So you basically flip one pole and try to make small cracks and aspirate them. Once aspirated, this is the next slide. Sorry, for want of time, I scrubbed. So this patient had the trifocal toric implanted at 180-degree axis, and she had uncorrected visual acuity of 6, 6, and 6. She was a happy patient. So these patients, there's very small room for error. You need to do them under topical anesthesia predominantly because it's more like a cosmetic surgery. And you need to have a well-centered rexis and the accurate markings. And the caveat here is the optical biometer or the intraocular lens power calculation. We use LensStar Pro 900, whereby we also use the universal Barrett formula for these patients. So this is another patient who I like to highlight, who was a 63-year-old Japanese male who's a myope, who had a central PPC or a PSCC, and he desires freedom from spectacles. He does drive occasionally at night. So keeping this in mind, we went ahead and implanted a CRV lens or the Synergy lens in his eye. Here you can see the Synergy goes through platinum unfolder, which is again docked onto this cartridge. Here the platinum unfolder is a screw type unfolder. Synergy lens has got a non-diffractive apodized optic where the posterior surface has got a wavefront optimized optic. So these lenses offer a continuous range of vision. The advantage of continuous range of vision is you don't have fixed focal points. You have like this rubber band effect of an elongated foci of the near and intermediate. These lenses are also amenable patients with slightly larger angle kappa. I'll be talking about angle kappa later. So once implanted bilaterally, Synergy lenses do offer very good distance near intermediate vision. This is another gentleman who was 30-year-old male who's a HR, who was a manager of an IT firm, and he gave a history of LASIK done around more than a decade back, and he came with cataract in that eye, which underwent LASIK. So he, again, he has always been spectacle free, but over the last 1.5 years post COVID, he had used topical steroid drops excessively for allergy, and he developed cataract, and he had residual astigmatism also in that eye. So we went ahead and implanted a toric lucidus. The lucidus is a refractive EDOF lens. Here the lucidus is a better suited lenses for patients who had prior refractive surgery, predominantly because they don't have much of diffractive rings here, so the glare and halos are much less. The lucidus lens is got both spherical and negative asphericity in the anterior surface. There's a central bump. It's very similar to supraphobe in focus lens. And this lens has to be customized because most of the Lucidus lens comes with two standard diameters. I prefer Lucidus toric for patients who had prior LASIK surgery or any refractive surgery. The Lucidus toric comes in two variants. One is 12 mm and 12.4 mm, and other is 11 mm. And the advantage of this Lucidus is it also has a larger optic size of 6.25 mm. So these myopes who have much larger bag, you always prefer to go with a larger optic size and a larger diameter of these lenses, because when you have a large bag and you implant a toric lens, there's always a chance of post-op rotation in these lenses. Here you can see again I do this nuclear flip technique. I'll just forward. This is the Lucidus lens. It's a hydrophilic acrylic lens. It doesn't come preloaded. You have to load it. It does go through a wound assisted incision of around 2.4 mm. I had to enlarge my wound. I normally do with a micro incision of 2.2 mm size. So you have a central bump in these lenses, which is not visible as such, but under the microscope at high map, you can see the positive asphericity in the center. So these are the other presbyopic lenses. I'll just scrub through fast for the want of time, which we implant. So we have the AT Lisa trifocal, which is a hydrophilic lens, the Physiol hydrophilic lens, which is again a quadrupod design. I've implanted more than 100 Physiol lenses, and these lenses have excellent near and intermediate focus, but the only on the flip side, they have certain degree of glare and halos. If the patient doesn't drive at night, it's the most desirable lens. It's hydrophilic platform again, and it's got a quadrupod. I never seen any PCO on these Physiol lenses. Then we have the own indigenous triphobic implant from Care Group. And of course, the Lucidus implant is my preferred go-to lens in patients who had prior refractive surgery. Thank you, sir. So I'm just going to end this talk with showing you the different types of intraocular lenses which are available now. So we have different types of presbyopia controlling lenses. So you have the refractive and the diffractive. The zonal refractive is pupil dependent, and the aspheric refractive lens like Technis, Eyehance, Vivity, and Magnificent, they are again not pupil dependent and they have less amount of glare and halos. The intermediate focus is better, whereas the near focus, you need to go for a micromonovision in the fellow eye. The diffractive lenses include the Technis multifocal, Restore, and the Accretive, the indigenous one. The EDOF diffractive include the Symphony or AT Lara, which is the Echelets, and the trifocal diffractive, which is the Panoptics, Physiol, and Triphobic. So there's no one lens which suits all. So my preference, we customize, we counsel the patient, look at their lifestyle, then decide on what particular type of implant we can go ahead. Thank you for your kind attention.
Thank you, Dr. Das, for the nice presentation.